I really would like to thank Tracy and Christine and all the LGSF board for inviting me here. It's a pleasure and an honor. And I'd like to spend our time talking about what Lennox-Gastaut syndrome is, the natural history of Lennox-Gastaut syndrome, and not just to provide information, but to get us all thinking about what can we do to improve on where we are now. Question one, is this going to work? No. Okay. So you've heard about Lennox-Gastaut syndrome, you live with it. I'm going to call it LGS just to go quickly, but it's a messy syndrome, and it has a really messy history. It was actually identified by Charlotte Gervais, but the credit was given to Henri Gastaut and William Lennox. It is an electroclinical syndrome. It's a clinical gestalt, and I think Tracy mentioned this. A bunch of things come together, you suddenly see a pattern. It's pattern recognition. In epilepsy, an electroclinical syndrome is defined or described based on the age at onset, the seizure types, the EEG features, sometimes the underlying etiologies. Sometimes it can be helpful in determining the course, unfortunately with LGS it is, and also by the other morbidities that occur with it. So how is LGS defined? Good luck. We can go to some of the expert resources. The Child Neurology Foundation tells us it starts in childhood. There are multiple seizure types. We see the high voltage slow spike and wave, generalized paroxysmal fast activity, PFA. We're told it has moderate to severe cognitive disabilities are common there, and multiple different causes. We can go to the ILEE website. The onset of seizures is in childhood. Tonic seizures are mandatory. Slow spike and wave, we're getting a pattern here. Cognitive impairment, multiple different causes. In the literature, the Camfields have written a lot about this. They too say that tonic seizures are required with other seizure types. The slow spike and wave pops up, profound deleterious effects on intellect and psychosocial function. And then let's go look at how it's been used in the randomized trials. The Rifinomide trial, for example. Children had to have atypical absence seizures and drop attacks, which could be tonic, atonic, or astatic, and then some others. And again, the slow spike and wave, that seems to be pretty common. And in the recent CBD trial by Oren Davinsky, we have the slow spike and wave again, and then 2 generalized seizures, including drop seizures involving the entire body. And there are lots of different seizures that can do that, actually. But basically, we're getting the idea of big, bad seizures. For me, this is the clinical phenotype. Early childhood onset epilepsy, really bad refractory seizures of a generalized flavor, a messy EEG, cognitive impairment and decline. And I've learned from my good friend Tracy that Lennox-Gastaut syndrome is really the founding member of the Really Crappy Seizure Club. Yeah, you know that, don't you? Let me tell you about those seizures. These are data from a study I did over the course of a few decades with some of my best friends in the state of Connecticut, including Rusty Novotny, where we identified all the children in the state who were first diagnosed by pediatric neurologists as having epilepsy, new onset epilepsy, and we followed them forward for many years. And this is the seizure profile for the first 9 years after diagnosis in the children who had Lennox-Gastaut syndrome. I'm not sure, the pointer's not going to help me too much. But what you see from the first year after diagnosis to the 9th year after diagnosis, and the color represents the seizure intensity. This is the number of days, not number of seizures, but number of days per year that seizures were occurring. And you can see that there are a few very light blue areas where no seizures occurred. That's good. But you can also see there are big splotches of the darkest color. That's where seizures were occurring pretty much every day. And there's some children who just for years had seizures every single day, multiple seizures. And I think there are many of you who live with that. At the end of the study, 15 to 20 years after diagnosis, we did have some children who, now adults, who were seizure-free for a year or more. Some were having sporadic seizures, but the vast majority were still having multiple seizures, if not daily, at least weekly. We've explored these seizures a bit more, and last summer I had the pleasure and also the rather humbling privilege of facilitating a workshop with parents of children with early life epilepsy. Not all Lennox-Gastaut, but we had Lennox-Gastaut represented, Dravet syndrome, KCNB1 related epilepsy, KCNQ2, and some others that I'm just learning about. We had about 10 parents, 3 pediatric epileptologists, and then some qualitative researchers, and we spent the day talking about what is it about the seizures? And this is a whole nother kind of natural history that I don't think many people think about, although many of you have lived it, but it's important for us to consider. But what is it about the seizures that cause burdens? And most people will say, well, it's how frequently they occur and how serious they are. And that's absolutely true, the frequency, the seriousness, but the piece that, and I think you know this, it's the unpredictability. You're walking down the street, you think you're going to the dentist office, and bang, you're in the emergency department. What just happened, right? And it's like walking through a landmine field. That would be one thing if it was a brief illness, bad week, and then you move on. But it's not. That becomes your lives. And what parents started saying was that this just changes the way you live. You can't make plans. It has an impact on the siblings. You're always fighting with insurance companies. You're having to manage all these multiple appointments. That chart that Jennifer just showed, that amazing chart of her life, the systems management chart. You have to educate other people. The new school nurse, you move to a new community, you have to go to the ambulance service and explain to them what to do when your child has a seizure. You have to live with a stranger in your home. Maybe you have home nursing care. It just changes everything. And as time goes on, what the parents started saying was, we live in overload, constant anxiety, guilty about never doing enough for my child who has epilepsy, for my other children who don't. There's this wear and tear on the families, the isolation, the desperation, the 24/7, 52 exhaustion. And as one parent put it, we're not thriving, we're just surviving. And one of the terms that we threw around was chronic traumatic stress disorder. And I think the talk that Jennifer just gave, that's your lifeline. Hold on to that, because the resources that she talked about are so critical. You have to take care of yourselves. It's not just your child who has LGS. Your entire family does. And you really do have to take care of your health. And that was something the parents said, that they didn't take care of their health. Not because they didn't care, they just couldn't get to it, you know? So take care of your health, because your kids are depending on you. This is the seizure rhythm that parents started to talk about. You're going along and boom, there's a seizure. And that involves maybe emergency medications, the EMS services, all the things that can go along with the crisis. Then there's the afterwards period, and that's when you have to deal with cleaning up, worrying about the injuries. Did my child get hurt? Are you now hurt? Oh my gosh, I missed my appointment. You're apologizing to people. When we're holding this after the actual workshop, when we were having phone conference calls to discuss how we put this information together, there was one mom who had been really, really involved, and she didn't show up for the phone conference call, and I got worried. And then she writes me this email apologizing for not making it because she was in the emergency department with her daughter. And I'm thinking, why are you apologizing? But you get the sense that you feel bad that you haven't done something yet more than what you're already doing. So you get over the aftermath section, and that's the time, that's when life goes on, right? You go to the grocery store, you go to the dentist, you take your kids to school, you take care of your other children. Maybe you say hi to your spouse, see your friends, go to a movie, I don't know. But during all that time, you're getting ready for the next crisis to hit. So it's just, I think Tracy said you're in LGS parole, you're in a brief period of respite, just waiting for that next shoe to drop. So that's the seizures. But LGS isn't just seizures alone, and you know that. Bob Fisher, in his description of what epilepsy says is that it's a disorder characterized by seizures, but also the neurobiologic, cognitive, psychological, and social consequences of the disorder. And this just starts to scratch the surface for LGS. This past year or so, I've also had the privilege of starting a project with a large number of parent organizations and a large number of parents, trying to understand better what the issues are, that you're dealing with in a way that's relevant to you and that can help us to study these conditions in a systematic way and then use that information towards developing trials that will demonstrate whether or not treatments help. But all of that aside, we've been working very hard to get an accurate description of what's going on, and the Lennox-Gastaut syndrome Foundation parents have been wonderful participants at this, and any of you in the room who have worked on this project with me, thank you very much. So we worked with parents, and this is very important. I and my colleagues, we didn't just come up with questionnaires and say, here, fill these out. We had, I'd say 50 or more hours of meetings with parents, asking them, what is it you're living with? What are you concerned with? How can I find out about that? What questions should I be asking you? And based on that, we've put together some initial projects, and I'd just like to tell you what the results have been, just this, again, the surface results for the Lennox-Gastaut group. Very similar to what Tracy told you from a much larger survey of Lennox-Gastaut parents of children with Lennox-Gastaut syndrome. The children are not children. They tend to be older. Half of them were mid-teens and into adulthood. And we see relatively fewer younger children. And there's a reason for that. One of the biggest issues that parents brought up were the seizures in sleep. Now, at the time that the survey was filled out, almost all of the children with LGS, or the people with LGS, were having seizures. It had at least one seizure in the past 6 months, which meant that they were having pretty frequent seizures. One or two was seizure-free. Of those who had had recent seizures, 81% had seizures in the past month, during sleep, okay? And if we break it down, how many seizures they were having, well, again, 19% none, but when parents said their kids were having seizures during sleep, it wasn't like one or two, it was a few nights a week to 39% of them said 6 to 7 nights a week, virtually every night, a lot of them. How do you sleep when that's going on? I have no idea. How about gross motor function? We used the gross motor function classification system, which is very well accepted and respected within the rehabilitation community. And it basically breaks motor function gross motor function into 5 categories, the top category being pretty much independently mobile, not especially atypical, able to walk, run, go up and down stairs without holding onto railings. The next level is a little bit more impaired, but not really, but still independent. And then we get into levels where there's device dependency. Independent with a device down to the level 5 where someone is completely dependent on a device and dependent on someone else to get around. And this is just function within a fairly small area, for example, the home, in an area where someone's familiar with their surroundings. And what you can see is that about half of the children are not device dependent in the home, but the almost other half are dependent to some extent on a mobility device, and a fifth of them were completely dependent on the device and someone else to get them around. How about hand function? A quarter of the patients, of the people with Lennox-Gastaut syndrome, did not have meaningful use of their hands to grasp and manipulate objects. This has a huge impact on things like eating. Only a quarter of the people were independent for eating. Roughly half needed some help, but 29% were completely dependent on someone else for their feeding needs, and that included some people who were completely G-tube dependent. What about toileting? Only 14% of parents said that their child with Lennox-Gastaut syndrome was fully toilet trained and independent in the bathroom. Another roughly third needed help, were not fully toilet trained but needed help, and 50% were completely dependent on a parent or caregiver for help in the bathroom. Communication. Only 5% said that their child was an effective communicator with people the child knew, as well as other people the child was not familiar with. 23% were effective, but a little bit slow. You have to wait a little bit harder, but still effective, independent communicators. The rest had more difficulties, and 40% rarely communicated, even with people they knew well, their parents and other caregivers. The primary mode of communication was language-based for a little over a third, but the majority were non-language-based communicators. That is, their primary, maybe not only, but their primary mode of communication was gesturing, vocalization, and eye pointing. Behavior, you've heard about that already. 60% of children or adults with Lennox-Gastaut syndrome had either a diagnosed or suspected behavioral problem. A lot of it was autism combined with, because these are not independent disorders, but combined with anxiety, depression, ADHD, and a little bit of aggression as well. Yikes. Where do we go with this? This is a tough disorder. Well, I'm going to be a little maybe negative, maybe cynical at times, but bear with me. We have focused so much on the seizures, and boy, those are really important, right? I mean, those just ruin your life. They ruin your hour. They ruin, just minute to minute. They can ruin your day. But so far, we've really focused on the seizures and treating the seizures, and I would say that the treatment is palliative, and I haven't heard anything here today to contradict that. And I would argue, with all due respect to the amazing studies that have been done, we're really kind of applauding mediocre success, and we're deferring consideration of what I think, who am I to say, but what I think the real problems are. Let me just give you an example, 2 examples. This is the Rifinomide study that Tracy Glauser did, brilliant clinical researcher and randomized trialist. What this study did was take patients with Lennox-Gastaut syndrome. They got pre-treatment measures of seizure frequency, and they showed that prior to starting the trial, either placebo or Rifinomide, the two groups had almost exact seizure counts for the 28 days prior. After treatment, there was a reduction for both groups. There's always a reduction in the placebo group. That's why we use them. They give us an idea of how much things change. So let's put this into sort of daily numbers. Prior to starting treatment, during the pre-treatment phase, both groups were having 3.3 big seizures a day. After the treatment phase, the Rifinomide group was having 2.2, and the placebo group was having 2.7 big seizures a day. So the Rifinomide saved us about half a seizure per day. It's better, right? I mean, you'd rather not have that extra half seizure a day, but these children were still having, roughly 2 to 3 seizures a day. We see the same sort of pattern in the CBD trial. Prior to treatment in the placebo group, you can see in red, this is the daily seizure count, 6.5, 5.9, 6.2 seizures a day. It's a lot of seizures a day. After treatment, we get down to 5.3 in the placebo group, 3.7 and 3.8 in the 2 treatment groups. So in the placebo group, that's our baseline for how much things change, right? There was a reduction of about 1.2 seizures per day, 2.2, 2.4 in the treatment group. So the treatment saved about 1.1 seizures a day. But these patients, these kids, were still having 3 to 4 seizures a day. That's still a lot of seizures to be having. It's better. I don't want to discount that. But it's not, I think as Tracy said, rainbows don't come popping out of your eyes, right? So 2 ideas I want to get across, very important. Lennox-Gastaut syndrome is not a disease. It's not like tuberculosis. That's a disease. Lennox-Gastaut syndrome, it's a syndrome. The diseases that cause it, and many people have talked about this already, but I really want to frame this in a very specific way. The diseases that cause it are almost anything, from acquired insults to brain malformations to neurometabolic conditions, specific genetic causes, and yet, many others that we have not yet identified, although we're working on it. Yet, the way we treat it is this one-size-fits-all. The expression, I've got a hammer, everything looks like a nail. We have a new drug. All these different people with Lennox-Gastaut syndrome who have different diseases are treated like a nail. And we hammer away at it, hoping that we'll solve a few of these. We are today in the era of precision medicine, right? That big word that we hear coming out of Washington. Precision medicine means we get a precise diagnosis we get the right tool for the job, we match the treatment to the disease, not to the syndrome, but to the disease, and we address the underlying disease process. And you know what? That's not new. That's the whole idea of medicine. It's just that when we don't have that precise diagnosis, we don't know what we're treating, we sort of throw things at random. But this is not new to medicine, and it's not new in the epilepsy, the neuroepilepsy space either. So I think Rusty Novotny already mentioned vitamin B6 supplementation for pyridoxine deficiency. Oh, you mentioned the ketogenic diet for SLC2A1 or GLUT1 deficiency syndrome, mTOR inhibition for tuberous sclerosis, and brain malformations that involve dysregulation of the mTOR pathway, and the list goes on. These aren't specifically seizure treatments. These are disease treatments. And the idea is we're not just trying to suppress the symptoms of the disease, suppress the seizures, we're actually trying to treat the disease, and that has the downstream effect of fixing the seizures, but also a lot of the other complications associated with the disease. That's one thing, and we need to think about that for people who have Lennox-Gastaut syndrome right now. The other point I want to make, and Tracy alluded to this, and that is that Lennox-Gastaut syndrome is the result of a process that's gone dreadfully wrong. It's a terrible error in neurodevelopment, and that error leads to all of the symptoms, the seizures, the intellectual disability, the dysregulated sleep, the dysautonomias, the eating, everything can lead back to that. It's a train wreck. My training is actually in epidemiology, and epidemiology is the research branch of public health. And in public health, we approach health problems within a very specific framework. And the first thing we ask is, can we just stop this from ever happening in the first place? Primary prevention. And primary prevention involves broad public health initiatives that affect the entire population. What do I mean? Vaccination programs. Okay, that's an example. Keeping the water supply safe, another example. Keeping ourselves fit, good diet, not smoking, all the things, just avoiding things that make us sick and not getting sick in the first place. It's a great way to do it. We can't do that for all diseases. The next thing is secondary prevention, catching someone who's at very high risk just before the disease actually becomes apparent, or even longer before it becomes apparent, and treating them early. Pediatricians do secondary prevention all the time for diabetes, for scoliosis, hearing, vision, all those things in the well-child visit. They're checking to see if there are any signs of something that could go awry so they can address them early. In older individuals, such as myself, cancer screening. Catch it before I become symptomatic, treat it early. If we can't do that, then we're on to tertiary prevention. Oh, and with secondary prevention, what we do is we focus on those people who are at highest risk. So instead of going to everyone as we do with primary, secondary is more targeted. Tertiary, you have now been declared to have a disorder, and now we're into treatment and trying to limit the consequences of that. And there are many different levels within that. The thing with these different levels of prevention is that what you do per person starts off very inexpensive. It doesn't cost a lot to treat someone, to vaccinate someone for measles. It costs an awful lot to treat them for subacute sclerosing panencephalitis. The further along the disease process, the greater the monetary cost, but also the human cost. So can we start thinking about Lennox-Gastaut syndrome not from the tertiary perspective, which is where we are right now, and it's often late tertiary, but could we move it up to secondary prevention? And that's where we need the natural history. And I'd like all of you to sort of be epidemiologists with me and just walk through the reasoning that we use in public health and epidemiology. The first thing we do is say, well, wait a minute, how many people are out there? Where are we going to find them? So the answer to that is if we start with all newly diagnosed children in the population who have epilepsy, and there are at least 3 studies that have done that, mine's one of them. The answer is that of all children with epilepsy, it's less than 1% present with the diagnosis of Lennox-Gastaut syndrome. That's really little. Realize this is only like 0.5% of the population, and less than 1% of that 0.5%. It is a little, small number. But here's the thing. If you follow those children after diagnosis, the children with Lennox-Gastaut syndrome start coming out of the woodwork. And the Camfield study in Nova Scotia, our study in Connecticut, both found a quadrupling, a quintupling in the number of children who ended up being diagnosed with Lennox-Gastaut syndrome. It's interesting because what happened was Lennox-Gastaut syndrome happened as we watched. Children start off with something else. They may start off with West syndrome, that's not uncommon, but they may also start off with a sort of nondescript, generalized or focal, non-syndromic form of epilepsy. And over time, the symptoms start to accumulate. And you know what? At least in this one study, it took a median of almost 2 years before these children met the criteria for Lennox-Gastaut syndrome. You know, congratulations, you now have a train wreck. It took 2 years, and we're watching them. That means half of them took more than 2 years. We're sitting there waiting. To me, that's a window of opportunity. The other thing we have to ask as epidemiologists is, well, you know, it's still a lot of kids who have new onset epilepsy. Is there a particularly high risk group? And the answer is there sure is. Infant onset epilepsy, okay? If we look at the children who had their first seizure in infancy, 13% of that group ended up having a diagnosis of Lennox-Gastaut syndrome. And it wasn't just the children, it wasn't just because of infantile spasms. If we take the infantile spasms out, 9% of children who started off having seizures in infancy, but not spasms, develop Lennox-Gastaut syndrome. If we look at the toddlers, it was 5%. If we look at the 3 to 4-year-olds, it's only about 2%, 1.5%. And older children, at least in this study, did not evolve into having Lennox-Gastaut syndrome, although a few did present with it. So we've got our high-risk group now. Why then are we waiting for this to happen? We know it takes a while. We know who they are. So what I'd like to suggest that instead of doing this, waiting till you meet those criteria for having Lennox-Gastaut syndrome and saying, congratulations, you can now be in our trial and we can try to palliate this horrible condition that your child has. Why are we doing that? Don't we need to do something else? I think we now have Lennox-Gastaut syndrome being a great way to organize families, to keep you together, and you do need that. And I don't mean any Please realize I do accept the importance of that. I more than accept it. But I think at this point, we're using Lennox-Gastaut syndrome to focus on treatment symptom suppression. And we're stopping to ask, we're not asking the questions. We get the diagnosis, and nobody says, well, why is that happening? Or, you know, we tried 1 or 2 tests and then we stop. We're not seeking those answers. It's become a parking lot of desperation. And this is, again, a little bit cynical, but I think it's become a fertile patient population to exploit for trials, for special clinics, and so on and so forth. And I wonder if this is really helping patients or just building careers sometimes. The way I'd like to encourage us to start thinking about this for a randomized trial is that we should start looking at who's at high risk, and start thinking about assigning them. Now, when I say assign, I don't necessarily mean in a randomized trial way, but in a quality improvement, maybe a non-randomized comparative effective approach, but assigning them to different treatments that may have a disease-modifying impact. And this is the trial that I would dearly love to see, a trial that says children who got this approach to treatment had a much lower risk of Lennox-Gastaut syndrome than children who got the usual approach. I think that could have a real impact for us. And you know what? We've kind of seen this happening already. In the West syndrome community, and many of you are here because a lot of children with Lennox-Gastaut start off with West syndrome. We now have guidelines and recommendations. The Child Neurology Foundation has this campaign, Together We Can Stop Infantile Spasms. There's even now a trial trying to treat children with tuberous sclerosis. I think someone mentioned it already. Treat children with tuberous sclerosis before they ever develop spasms, and trying to prevent spasms in the first place. True secondary prevention, right? You've got a high-risk situation, you treat it, and you don't let the disease fully express. I'd like to suggest that future goals for Lennox-Gastaut syndrome treatment should start focusing on the specific causes. And we should see if there's a way to treat that, to improve. I know there are always going to be impaired outcomes once someone has Lennox-Gastaut syndrome, but to optimize what's there and to improve on what's there. And then, going forward, we should really try to nip it in the bud. We know who the high-risk groups are. We don't yet know what the effective or early or preemptive intervention strategies are. But I think we could figure that out. But it's going to take some work, but we can. And wouldn't it be cool if CNF's next campaign looked something like this, right? So I'd like to end this with just a few comments. I feel like some of my thoughts might be a little bit negative, a little bit discouraging, but one of the things that's been such a pleasure for me has been getting to know parents like you and getting to know your young children and young adults. And as part of our natural history study, one of the questions we asked, it was very important to me to have some positive features in there. One of the questions we asked was, what activities do your children enjoy? And this just gives you an idea of what people from the Lennox-Gastaut community talked about. And I would want to emphasize the importance of music. They love listening to music. Does that sound about right? Yeah. They like being sung to. Some of them like playing instruments. That is limited by hand use. They like singing songs. And someone mentioned water. They like playing in water, right? One of the last questions we asked was, what is your child particularly good at? And what are you most proud of? And this was a very quick Wordle that I put together, but I just thought you'd enjoy seeing it. The big word that came out in the middle was loving. And that just is a reminder that we need to hold together, and I think we have a way forward if we work together on this. Thank you.